This is Mr. G giving you lecture number 27-2, Meeting Nutritional Needs. This lecture is a little different because I'm using a slide, a PowerPoint that I had prepared last year. I wasn't happy with the PowerPoint that the publisher has made for this this chapter. So I will send you these slides so that you have them. So the lecture is on meeting nutritional needs. So let's talk about what factors might affect eating and nutrition. Well, there's age, religion, illness, body reactions, finances, culture, appetite, personal choice, and disability, and we'll go over each of these. So with age, babies begin with breast milk and formula, and foods have to gradually be added as they are able to tolerate them. And then with older people, both taste and smell are decreased. And that's why a lot of older people don't have much of an appetite, because they just don't feel like taste anything tastes good. And then also the secretion of their digestive juices decreases, so as a result they tend to not tolerate foods as well. With culture, all of us are from different cultures, and so you can appreciate the different things that culture will influence the diet. Here are some examples. In Mexico, they eat a lot of rice and beans. The Philippines eat rice with every meal. In Poland, they have a very high fat and starch content. China is low in fat but very high in sodium. And then India, Hindus do not eat beef. So those are all examples of how culture can influence the way people eat, and as a result, their diet. Appetite is a big thing. The desire for food. There's nothing worse, I can tell you, than when somebody loses their appetite. That term is anorexia, a loss of appetite. Can be caused by illnesses, drugs, anxiety, pain, depression, unpleasant sights, thoughts, and smells. So it's important, especially with the last factors of things that can be avoided, that when somebody does not have an appetite, that you try to avoid things that will decrease their appetite even more. And a big thing we forget too is that anxiety and pain will cause people to lose their appetite. Appetite can be stimulated by smells, by thoughts, by visual cues. That's why it's very important how a meal is presented, because if it's not presented very well, it will not stimulate people's appetite. So especially when somebody is anorexic, you want to be sure to make their food as desirable as possible. Illness also affects your appetite. It's usually decreased during illness, and the ironic thing is that nutritional needs are generally increased during illness, especially for things like cancer. When you're vomiting and diarrhea, you need to replace what you're losing, but many times you don't have the appetite to do that. Blood loss will take a lot of iron from your body, and therefore the need for increased amounts of meat and green vegetables will be increased, but the appetite is not there. And then infection will also increase nutritional needs. Poor nutrition is very common among people needing long-term care, and you will see that when you are doing your clinical at Menorah Manor. That's just a few of the things that will cause. Some of the other things that I didn't go into depth were body reactions, such as if somebody gets bloated with certain foods or it makes them nauseated, they're going to certainly try to avoid it. Finances are huge. We talked about that in the last lecture. Unfortunately, the very nutritious foods, such as fruits and vegetables and lean meats, are usually more expensive, so therefore it can influence that. Another thing that I didn't talk about was also disability, because somebody who is disabled, because they have such difficulty with trying to eat, especially if their hands are involved, or even any of the mouth muscles or swallowing muscles, it will make eating difficult for them, and therefore they may try to avoid it. So there are special diets that may be ordered by the physician, In the new book, those special diets are on page 451. So that notation is from the old book. Special diets are ordered by a patient's physician, therefore they really need to be followed. For nutritional deficiencies, diseases, these orders that the doctor will write are for nutritional deficiencies, diseases that they might have, weight control, also conditions like surgery. After surgery, the special diets need to be ordered until the patient's gastrointestinal tract can tolerate food. So it is very important for the CNA to know the diets of the patients that she or he are caring for. So you need to keep an eye on the care plan for those specific diets. So let's start with clear liquids. Clear liquids are essentially any liquids that do not contain any milk. They leave only a small amount of residue, and residue is anything that is left over after the digestive process. So things that cause a small amount of residue result in a small amount of stool. Clear liquids are generally non-irritating and non-gas forming, which is very helpful, especially after surgery. Sometimes with some illnesses, just starting out with clear liquids will help them resume a regular diet, but you have to do it slowly. Somebody who has nausea and vomiting may need to be put on a clear liquid diet so that they can get fluids, but it's less of a stress on the GI tract. And then any gastrointestinal preps, such as when somebody's having a colonoscopy, many times after they've been cleaned out with the laxatives and enemas, they will be kept on just a clear liquid diet since it will not produce any residues. So examples of a clear liquid diet, and unfortunately my icon here is blocking, I will move that, include water, tea, coffee without milk or cream, carbonated drinks, gelatin, popsicles, fat-free broth, and hard candies are all things that would go on a clear liquid diet. Now, full liquids are liquids that at room temperature, full liquids are liquids at room temperature or they melt at body temperature. And so examples of that are like gelatin. Gelatin, once it reaches body temperature, it melts into a liquid. So some uses of a full liquid diet are once again post-operatively after an operation, as you increase the diet slowly right back to regular food, you usually go from clear liquids to full liquids to a soft diet and then a regular diet or whatever the patient's pre-operative diet was. So other uses are nausea and vomiting, once again, as you're bringing the person back to a regular diet from an episode of nausea and vomiting. For people unable to chew, swallow, or digest solid foods, you may put them on a full liquid diet. So examples of that are any clear liquids are allowed on a full liquid diet: custard, eggnog, strained soups, strained fruit, vegetable juices, sorry for that typographic, milk or milkshakes, strained or cooked cereals, plain ice cream and sherbet, pudding and yogurt. So those are all examples of what you would see on a full liquid diet. Next is a mechanical soft, and a mechanical soft is semi-solid foods that are easily digested. Once again, that's an advancement from full liquids for patients who have had surgery and are easing back to a regular diet. Anybody with chewing problems, anybody with any gastrointestinal disorders that might not be able to tolerate more aggressive foods that need a lot more breakdown during digestion, or infections. Examples are all liquids, eggs not fried, broiled, baked, or roasted meat, fish, or poultry that is chopped or shredded, mild cheeses, strained fruit juices, refined breads but no crust, and crackers, cooked cereals, cooked or pureed vegetables, cooked or canned fruit without skin or seeds, pudding, plain cakes, and soft cookies without nuts or fruits. No nuts or fruit, nothing with nuts or fruits, because fruits have a lot of roughage, especially when they're not peeled. Next is another diet you might see is advanced as tolerated, or DAT it's sometimes referred to, or diet as tolerated. And this is usually ordered postoperatively as patients recover from anesthesia and regain their GI function. The doctor may put this order, and it leaves the decision making to the patient's nurse, and that is eventually communicated to the team. So you may see that an acronym of diet as tolerated. The next diet is low residue. Low residue, as I talked about earlier, residue is what remains after digestion. And so foods leave us that on a low residue diet leave a small amount of residue in the colon. This is frequently ordered for people who have diseases of the colon, such as colitis or Crohn's disease, as well as people who have diarrhea. Examples: you don't want any foods high in fiber, so that it would include fruits and vegetables, whole wheat, bread, grains, nuts. So anything of that sort would be avoided on this diet. A bland diet. Bland diet is foods that are mechanically and chemically non-irritating and low in roughage. They're served at moderate temperature, so you don't want any strong temperatures, either cold or hot, and no strong spices or condiments. So essentially, something very blah. Uses for this is anybody who has ulcers that might need, might need a rest because the ulcer is healing. Any gallbladder disorders, some intestinal disorders like the Crohn's and the colitis that I talked about earlier, and then after some abdominal surgeries, the patient may be placed on a bland diet. Next is a diabetic diet. We're going to spend a little bit of time talking about that because you're going to see a lot of diabetic diets. They're generally designated with the initial ADA along with a calorie designation. So you'll see like 1,800 calorie ADA diet. It includes the same amounts of carbohydrates, proteins, and fats at the same time each day. And the reason why it's regulated like that is because many of these patients are on insulin, and each type of insulin has different times that it peaks. Some of them it's 4 hours after they get the insulin, some of them it's 6 to 8 hours. So because of that, the meals have to be regulated very carefully so that the patient doesn't develop any hypoglycemia, which we'll talk about shortly. Sometimes, many times they'll have between meal and bedtime snacks to make sure that there's no gaps that will cause them to bottom out from the insulin that they got. So it's important for the CNA to remember that many times insulin or blood sugar checks are scheduled around before meals. So you want to check before you give a diabetic patient their tray to make sure that they don't have any of those blood sugar checks or insulin to be given. All right. So let's talk about signs of hypoglycemia or low blood sugar. They include shakiness, feeling shaky, sweating, chills, clamminess, confusion, including delirium. So delirium is a temporary confusion. It's like a dementia, but it's an acute onset, and it's usually an acute recovery as well. Lightheadedness or dizziness, nervousness or anxiety, irritable, impatient. They can have a rapid, fast heartbeat, or they can just feel hunger or nausea. So you can have all of those symptoms, and you can have just one of them. So it's very variable depending on. So hypoglycemia, of course, is low blood sugar, but so it depends on how low the blood sugar is. The lower it gets, the more symptoms the patient will probably have, and it can eventually lead to a coma state. So it's important that you recognize the hypoglycemia early. It's something you would report to the nurse right away. Another diet that you may see is a low-fat diet, and these are just diets that are low in fat and prepared without using any additional fats such as butter or oils. Uses for it is hyperlipidemia, or a high lipid or fat content in the blood, heart disease, cardiovascular heart disease, any gallbladder disease, because gallbladder stores bile, which is made in the liver, and bile is the digestive juice that breaks down fats. Also, any disorders of fat digestion. Some people have difficulty with fat digestion based on decreases in their pancreatic enzymes that break down fat. Liver disease is another reason why you'd want a low-fat diet, and diseases of the pancreas, because the pancreas does produce lipase, L-I-P-A-S-E, which is an enzyme that breaks down fats. Next, we'll talk about sodium-restricted diets. Most sodium, one of the things it can do is cause retention of fluid in the body. And for people with high blood pressure, that can make their blood pressure worse if they have more fluid on board. Also, people who have congestive heart failure or heart disease, they may be on a low sodium diet as well. So NAS is no added salt, and that means that you don't want to give them a salt shaker. Or anything that's high in salt, like potato chips or something that's prepared like that. More commonly, you'll see what's called a 2-gram sodium diet, and what essentially it is a diet that restricts the amount of sodium in one day to 2,000 milligrams, or 2 grams. Once again, the uses of this diet are heart disease, hypertension, fluid retention, any liver disease, and any kidney disease, because both of those organs deal with some aspect of of sodium metabolism. Last thing we're going to talk about is a dysphagia diet. Dysphagia is the difficulty with swallowing. And so when you have difficulty swallowing, there's the fear that you will aspirate. And aspiration is breathing in a fluid, food, vomitus, or an object into the lungs. So it's when you take anything other than air through the into the respiratory tree. Food thickness is changed to meet the person's needs many times, because sometimes they may have difficulty swallowing, and the problem mostly is with thin or liquids, and so they will add things to liquids to make them thick so the person is able to swallow them. A doctor, a speech pathologist, an occupational therapist, a dietitian, and a nurse will choose the right food thickness. So you will see when you go to Menorah Manor a number of people who have different food or liquid thicknesses ordered. So thickened liquids have no lumps. They're pureed with milk, gravy, or broth added to some of the pureed foods as needed, and you stir before serving. Then there's medium thickness, which is the thickness of nectar or V8 juice, and you want to stir that before serving as well, and that's usually called nectar thick liquids. And then extra thick or honey thick, it mounds a bit with a spoon, so when you pull a spoon out of it, there'll be a little mound that forms. It's generally drinkable from a cup, and once again, you want to stir it before serving. And then there's yogurt thick, which is thick like a pudding or a yogurt. It holds its shape, and it's served with a spoon. But most of the people you'll see at Menorah Manor are this thickness here, honey thick. All right. All right, and then pureed is, when liquids are, when solids are broken down to a almost liquid state, and those may be thick like mashed potatoes, and they will mound on a plate. So that's a pureed diet. Next slide. All right, so let's talk about dysphagia a little bit, because you need to be able to recognize the signs and symptoms of dysphagia. So if the person avoids food that need chewing, If the person avoids foods with certain textures or temperatures, the person tires easily during a meal because they are not realizing that they're working so hard on trying to swallow the foods, prepare it and swallow it, that they may tire easily. Food might spill out of the person's mouth while they're eating. All right, that might be a good indication that they have some dysphagia. They pocket food or squirrel it in their cheeks. That's also because they know that they have difficulty with swallowing it, so they avoid that. The person might eat slowly, especially solid foods, only because they are working so hard to make it, easier to swallow by chewing more. The person complains that food will not go down or that the food is stuck. That's another thing that the patient might show. And the person might frequently cough or choke before, during, or after swallowing. So the person regurgitates food after eating. The person spits out food suddenly and almost violently, all right? So it's almost like projectile coming out of their mouth. So that should make you think of dysphagia. Food comes up through the person's nose. The person is hoarse, especially after eating, and because of that, what's happening is some of the food is getting past the vocal cords and irritating them and making them hoarse. After swallowing, the person has gargling sounds while talking or breathing. That's another good indication that they might be having trouble with swallowing. The person has a runny nose, sneezes, or has excessive drooling of saliva. Those are all things that might give you an indication that somebody has dysphagia. They also might complain of frequent heartburn. And their appetite may be decreased because they essentially are trying to avoid eating because they know they have such difficulty with it. So in these cases, when somebody has been diagnosed with dysphagia, that generally will be done through a speech therapy consultation and probably some x-rays to show the swallowing abnormalities. The patient will be placed on aspiration precautions. Those include positioning the patient in a Fowler's position or an upright in a chair for meals and snacks, and you want to maintain that position for 1 hour after eating. All of this should be written in the patient's care plan, but if you hear that anybody is on aspiration precautions, you should be mindful to make sure that you follow through with all of these things. You want to support the upper back, the shoulders, and the neck with a pillow to make sure that they are very upright. Observe for signs of aspiration during meals and snacks. Check the person's mouth after eating for any pocketing. Check the inside of the cheeks, under the tongue, and on the roof of the mouth, because as I talked about earlier, these patients will frequently squirrel their food. And remove any food that might be left in there so they don't choke on it. Provide mouth care after eating, just because they may be retaining food in their mouth. And then report and record your observations. Report immediately any choking, coughing, difficulty breathing during or after meals. Okay, the next section is fluid balance, and we'll deal with that in the next lecture. That will end this lecture for today, and thank you for your attention, and we will see you in class.